The broadcast is now starting. All attendees are in listen-only mode.
Hi, everybody. Thank you for tuning into today's webinar. We have an awesome presentation today lined up with Katie O'Connor. Katie's going to walk us through how to adapt an EMS simulation to the online social distancing environment. I just want to say a quick thank you to iSimulate for their sponsorship of today's webinar. iSimulate provides smart simulation solutions that are used by organizations across the world. They use the best of current mobile technology to create products that are more realistic, cost-effective, and simpler to use than traditional solutions. Our presentation is going to feature some iSimulate products. In the follow-up email you receive after today's presentation, we'll have links and contact information so that you can get in touch with iSimulate. The follow-up email will also include instructions and a registration link for how you can receive 1 hour of CEU credit for this webinar. During the presentation, if you have any questions for Katie, please feel free to submit those questions in the questions section of your GoToWebinar control panel. We'll collect those questions as we go, and if we're able to address them at the time, then we'll get to them, but we'll have a Q&A session after the presentation where you'll be able to have all your questions addressed. I think that's about all I have. Katie, I really appreciate you taking some time to be here. I'm really looking forward to this presentation.
Yeah, glad to be here. I'm happy to share some of the stuff that we've been able to do at UCLA and answer any questions. So if you have questions, just throw them in the question box or the chat. I'm looking at both of them. If I get a little wrapped up in something fun, I'm sure that Nate will let me know that you guys are asking about something different. So let's get started. If you don't know who I am, I'm the assistant program director at the UCLA Paramedic School. I have like a little bit of a passion for simulation in health sciences, and did some simulation when I worked at GW's medical faculty program, and then also with the community college and nursing programs in Northern Virginia, and I got to bring that out here to California. And now I've gotten to bring it to Zoom since we are under a stay-at-home order here in LA, and so we're not allowed to have any campus interaction, so not even like 6 feet apart. All of our offices are closed, and we kind of had like about less than 24 hours notice to shift from in-person all the way to online and keep classes going. And we had a 48-person paramedic class that we had to figure this out with. So this is kind of some of the stuff that we've learned as we trialed and erred. And I was hoping that I could give you a presentation that will give you something to do. So I've included some QR codes with some of the cases that we did and some of the PowerPoints we made, so that you can actually like implement this if you need to when you go out. And then I'm going to give you like best practices or things we learned about the hardships that students were facing and how we kind of adapted to that. And what we did as a staff when we were teaching from, I think for the first week we were online, it was like hours from like 7:30 in the morning to close to 10 p.m. at night, because the students had like proctored review sessions in the evening to help them with some of the concerns they were having. Really, it was just like stress management. And so we didn't really have any planning time for the next day. It was literally like, we're doing this on the fly. Ed's lecturing and I'm making up PowerPoints, and Jesse's helping me transition our simulations onto online. So how can you do this without spending 2 weeks worth of planning, since everyone's trying to do this right now, this minute? What I didn't put into this presentation is like virtual reality. We don't have any of those Oculus systems. We didn't have any of that here at UCLA. It wasn't something that I could get spun up in the time. And we don't use the LMS systems like, I don't even remember what they're called, Canvas or Blackboard. Only platform I'm really familiar with is Zoom, so I'm pretty sure that this would work across other ones, but I wasn't going to spend any specific time talking about that. Have no idea when we're getting back to normal or what normal will look like, so can't really answer those questions. And then I'm not going to talk in depth about configuring Zoom settings or how to share and mirror your iPads or use iSimulate. Actually created some like short videos and posted those on the NEMSI forums, so you could find that there. I'm happy to actually make more or do like a little tutorial with people later, but I wanted to speak more to meaning objectives and how to continue learning, since people might use this with a different platform or with a different type of monitor system. First thing I need to do is thank everyone who made this work. So again, we had like less than 24 hours notice, and we were in the middle of our cardiology block. So we had just finished teaching EKG, and then we were going to teach all of the rest of cardiology to primary paramedic students, and we had to figure out how to do it online. So my staff at the paramedic school was instrumental in making this work and completely willing to try something that we'd never done before. So I wanted to thank Colin, Jesse, and Ed. And then Wayne Perry from iSimulate also joined our team, jumped in, had an iSimulate at his house, and like, I think with maybe 10 minutes of me saying, I need help, he's like, no problem, I got it. I can teach your kids how to use a monitor. So thank you to them. I'm just kind of presenting what they were able to actually do. So it's really to their skills as educators that it went well for us. So again, we were just finishing teaching up EKG, and then we were going to go right into ACLS. So our initial thought was, well, we'll just transition to HeartCode online. That's the ACLS platform that American Heart Association has. It would have them do their pre-test, their post-test, and there's lots of built-in virtual reality type simulations. But then we were discussing that, and my history of using that program at GW was that people spent a lot of time trying to figure out the game, and if they weren't using ACLS on a regular basis or weren't refreshing, that HeartCode was really too hard for primary learners, and it was going to do something like take 12 to 14 hours and then trying to click through these algorithms without really having any education on it to begin with. So we decided we needed to do some more primary education, and that paramedic students in particular needed other things to meet Appendix G requirements, to talk about cardiovascular emergencies, and even just to discuss the knobology of the monitors that we use here in LA so that they would be ready to go when they hit the clinical and field setting. So how are we going to do skills? Well, we'll figure we'll do them through Zoom, and that we'll use the iSimulate to try to do all of the knobology stuff, and then to do all of our rhythm identification and application. So this is the HeartCode lesson plan. We decided to buy the HeartCode ACLS for all of our students, and then supplement that with in-person synchronous Zoom sessions. And when we looked at what we had already done in the program, we already teach BLS to the students, and so we've already done basic adult and pediatric and child CPR. So we had those things already done. We also had already done our airway section where they had done airway management, intubation skills, supraglottics. So really the things that we were missing and that we hadn't covered yet was technology review. We hadn't been broken out any cardiac monitors in our program so far, and we hadn't done any of the mega code. So technically the HeartCode class was going to cover tachycardia, bradycardia algorithms, but we thought, okay, well, why don't we go ahead and cover those as well? And it'll give us double practice for paramedic students who also need team management, team dynamics, communication skills, patient interview skills, assessment skills, and really help with the critical thinking of, is this a stable patient or unstable patient? So we thought we could expand on that. So that's what we decided to do, and we started with a Zoom whiteboard session to review all of the ACLS algorithms. We also put together a PowerPoint using all the resources that the American Heart has for free on their website. So we just downloaded the high quality pictures of the algorithm cards and included that in a presentation that the students could then have a resource. So it really took the place of pocket cards or an ACLS textbook that they would have used if they were in the classroom with us. And then we created breakout sessions in Zoom so that they could actually interact with the monitors and do the ACLS cases. Again, we had no time to do this, so we literally used the cases that were already given to us in our ACLS instructor manuals, and we just went through these cases online. And then we added a breakout session with our static cardiology, and we just used the Zoom to share the screen of what we would normally hand to the students if they were practicing static cardiology in our in-person station. So here's just a couple pictures of my terrible handwriting on the Zoom whiteboard. And this is literally the whiteboards that I would draw out when I first started teaching ACLS, and then have been teaching it for a few years now. And I just would write this on a whiteboard. And it's exactly how I would have taught it if the students were in person. So I figured, why try to change something for Zoom? They had a whiteboard feature. I could whiteboard and literally use my same instructional methods, but just in a distance, and it actually worked out really well. The cool thing about the Zoom that I hadn't thought of before is it saved the whiteboards. So the students were actually able to refer back to it. And that had been one of the complaints that they had previously was, I do all of these drawings on these whiteboards we have at the front of our classroom, and then I erase them, and they don't have it to study from. So it almost was like a benefit to have to do it on a place where it recorded it, although my handwriting's terrible and it's not great. So this is a video of one of our first breakout Zoom sessions. And I took the sound out and sped it up. It's actually 30 minutes. But I want you to take note, the way we did knobology is by sharing the iSimulate screen, we were able to circle the buttons and actually have the students learn how all of them work. Now, they're not actually hands-on and touching it, and I know that there is a thought in EMS education that all of our learners are kinesthetic learners, and if they can't touch anything, then they can't learn. I sit next to Dr. Davis at UCLA a lot, and she teaches the PhD education course, so I've, I think, absorbed stuff from listening to her teach that class. I keep telling her I'm trying to get my PhD without actually paying for the tuition. But we know that that's a preference of learning, so that students, as long as we can engage them, can actually learn through auditory and visual methods. So we were really successful with this, and there's some fancy actual research done in the nursing realm that students get as much from bedside or watching simulation as they do from actually participating. So from the students watching me hit the buttons and use the annotation features in Zoom, they should be getting similar experiences as if they were hitting the buttons themselves. At least that's what the science tells us. And I have a couple statistics later from our particular class, and this is exactly what we found. So that by allowing the students to see the buttons, tell me which ones to click, to annotate the screen themselves and say, I'm gonna hit this charge button, I'm gonna go up on energy, that when we ask them questions later in our quizzes and in our exams, that they were actually performing better than when we had them all kind of crowded around one monitor and would do a technology review in a very traditional setting. So I'm not sure how you guys are doing your technology reviews for ACLS, but we would have groups of anywhere from 5 to 8 students, depending on how many were in the class, and they would huddle around one real life pack and have an instructor just real quick go through all the buttons and then put them into a scenario where they would inevitably have trouble remembering what buttons to hit. So this online review allowed all the students to see without having to crane their necks over someone else, and allowed us to stop and pause and actually let them try to annotate the screen so that they could figure out what the buttons were. And then they asked questions about things that I would normally not even have covered. So it was great to have a lot more rich interaction. We did this with about 10 students in each group, and we had multiple instructors in different breakout rooms covering monitors they were more familiar with. So I picked the Life Pack because that's what I used when I was paramedic, and I have not been very good about learning the Zoll, even though it's the monitor of choice here in LA, so I've got to get on that. This is how Wayne from iSimulate did it. He joined our class again, and instead of sharing his screen, he actually just pointed his web camera at his training unit. And then he used the stylus to point to the different monitor buttons. And he used both the Zoll and the Life Pack screens. And what he did was he actually would have the students review the monitor screens and then work them through a case. So as they were working through a case and someone was being the team leader, they were then also being the person who was in charge of the monitor. So either way it worked. The students didn't have a preference to if we shared the screen through screen mirroring, or if they actually just had the video camera looking at the iSimulate, they were able to see everything the same way. So both types of technology work really well. I edited out the students, but our students all have their cameras on. So when they talk, the students come up and we see them on the screen. And we also use the chat function. So after they learned the monitor, we started incorporating more team member dynamics. So this was our first how we got through the technology review station that you would have in your ACLS class. This is what I was referring to, and here's a QR code for you. We used the resources the American Heart Association already had, so we didn't have to create any slideshows. We just pulled the high quality images off their website. They have them already pre-made in PowerPoints for you. And then we were able to post this for our students so that they would have access to it. If you work for a fire department or a healthcare system, you may be in the same situation we were in, where we were librarying our books. So the students now no longer have access to the library because they're at home, and they also had no time to order a book. So we wanted to make sure that they still had resources in addition to the Heart Code course. So just pulling free resources that are available on heart.org and created a little PowerPoint, added them together. So I'm sharing that with you guys here. And then this is the first iteration of what we ended up doing. So this is literally case study from the instructor handbook, and we just took the initial assessment and put the information in the slideshow. And we had one of our ACLS instructors from actually the ENT program here at UCLA, who then ran through this case with them. And we started with static strips and just like a picture of the vitals and just typed it in. And then in the instructor notes, it was all of the stuff that's on the scenario card from the ACLS instructor handbook. And this actually worked really well, and it wasn't too overwhelming for the students, and they were able to have all the same discussions that you would think of in your first like learning station for either tachycardia or bradycardia if you're teaching a traditional ACLS class. So once we started getting past this idea of the format of what a megacode would look like and what we're asking the students to do, we upped our abilities and we started incorporating live monitor shots into the case. So we actually added in cardiovascular emergencies, and this is an example of, we use the AMLS cardiac case number 3, and we put together pictures of the monitor. And so initially we started out with either static screens for our instructors who didn't have an iSimulate device at their home. And then if you were an instructor who happened to have an iSimulate device at your house, they actually screen shared and would have the students, again, annotate what button they wanted pressed, and they would press it and then work through the case that way. And so it was very real-time, interactive, and to make sure that they were doing proper team dynamics and communication, they'd have to assign somebody in their team to take vitals. So instead of just having vitals displayed on the screen, we would initially have a monitor screen that had just the SpO2, because typically when they came in, they could put the SpO2 on a patient who was conscious, but they didn't get the EKG leads on right that second. They had to assign it to a team member, and then we would delay and have the team member put the EKG leads on. If they asked the team member to get vitals, we would use the private chat feature and send just the team member who was getting vitals one vital sign kind of at a time, so that they then had to figure out when there was the right time to interrupt the team leader and provide that information back. One of the things that we find is really difficult for the paramedic students is when they're operating as a team, especially when they're first learning cardiology, they're all trying to be team leader, and they all are jumping in with the right information and maybe not even listening, or they're going down their own rabbit holes. So by forcing them to have to communicate, especially in the Zoom setting, where if they talked over each other, they literally couldn't hear each other, or their screens would shift. It really focused them on their communication strategies and making sure that they were working together as a team. We also required them to input all of this into FISDAP as if it was a regular in-person skill session, with just a note that this was a Zoom class. So we notated in the shift in FISDAP that this was a Zoom class, so that we can track that for looking at data later. But once we required them to do that, they then realized, oh man, we really need someone to document this, because we're hitting 4 or 5 cases in an hour, and that's a lot of information for us to remember, and we can't live document into FISDAP, so we need a recorder. And I don't know about your programs, but at UCLA, the students, for whatever reason, like refuse to record things, and then they just keep asking us the blood pressure over and over. So by forcing them to kind of come up with a strategy for how they're going to record in codes, it really helped us lock in that objective that in person we've had trouble making headway with. So that was what we did for cardiology, and we were all worried, I'm sure, as most of you guys are, about how is this going to work? Is it going to be effective? Are they going to learn anything? Are they engaged? Are they paying attention? Generally, we felt that they were engaged and paying attention, but when we had them take the cardiology block exam, this is one that had been given by UCLA for years, and so there's a pretty good chunk of students who had taken it. We have rather large classes here. So we looked at the average for our previous cohorts that had completely in-person, traditional style teaching, and then we looked at what had happened with this class who was interrupted halfway through, and their cardiac exam score increased by 4%. So the average for the whole cohort went up. And these are just some excerpts of comments that the students made on their evaluations around cardiology and some of these online skills. The biggest thing that we found was every one of our instructors commented to us that the questions the students were asking were significantly elevated into critical thinking level questions. So most of the time when we were introducing cardiology, the students would get so caught up in the monitor and pushing the buttons and like looking at the screen, or they had just come out of doing all their IV med administration skills that they were really focused on pulling up the medications and getting an IV, or they knew that they had like 2 or 3 airways left that they had to get for FISDAP. So they were just trying to intubate everyone, not even thinking about if it was appropriate for the situation or not. They were just like, I need to check that box on my FISDAP, so like, let me do that. Here, because we took out those hands-on skills, they actually really focused on the assessment, the differential, considerations about atropine versus pacing. We had really amazing, great discussions. They were looking more at 12 leads and looking at just intricate things about the EKG that they never really would have cared about before. Most of our in-person skills were just rattle off the ACLS algorithm and move forward. But here on Zoom, because we kept it with like real time, there was a lot of forcing them to think about things. So the H's and T's conversation became like, well, what are we actually thinking about for H's and T's? What can we do? Versus listing them off, let's move on, and then give another person a chance to put a needle in a mannequin's arm. So for us, we really increased the learning objectives to a higher level. And that we saw that when we did our assessment of the students. So it worked for our medical simulations too. So we were like, okay, this is working. We're getting better at it each time we go. So we decided to, again, use the scenarios we already had. So we just had a meeting with our skills team and said, what scenarios do we have that will translate really well to this environment? So we want things that are all about making a differential diagnosis, about assessments, things that are maybe difficult questions to ask, or things that students maybe have trouble asking or coming up with the right wording or phrasing for. And then we were really lucky. I had no idea how we were going to get simulated participants to participate, because most of the time when we're on campus, the only people that we can get to come volunteer as patients are people who want to get into our program. So we have a competitive application process here, and you can get points towards your application if you volunteer as a patient. So all of our patients tend to be young guys that are very healthy and are from anywhere from 18 to like 25. We have some old people wigs that we like put on them, and we try to pale them up, but it's for sure not very believable. And they also work with most of our students. So when our students are doing abdominal palpations on their pals, or when they're like asking silly questions to the people they know in their class, they tend not to have the same level of realism or fidelity that we would see when they're talking to a stranger. So it's the same reason why they use standardized patients in medical schools and for high stakes exams and testing, is you just get a different response from the student. It's a different learning environment than when they're just practicing on their peers, which is great. Like, they should definitely practice assessment questions on their peers. But being on Zoom, we no longer had a limitation of who will drive to LA in the middle of the day for a few hours to listen to paramedic students ask them strangely worded questions that then have to be trialed and errored. This now became well, anyone could come to our classroom from literally anywhere around the world. Why don't we take advantage of it? I was lucky enough to have a bunch of people respond on social media from my family and from friends. And some people I had gone to grade school with ended up becoming actors in New York City, and they had some people who had worked with them in improv that were not working because everything was shut down. So they had some time on their hands. And we also tapped into this amazing network of EMS instructors who either are retired or had been working on pausing their classes and switching them online. So we ended up with all these educators of all different ages, all different backgrounds, all different types of appearances. And it really just jumped the fidelity level for our students up huge, taking advantage of the fact that we have to use people who are far away. We're not using people who can just make it to the school. It also allowed us to have very like chunked up sessions. So instead of having an all-day skills day where you expect someone to come to the school all day, they could just Zoom in for an hour, and then another person could Zoom in for the next hour for the next skills rotation. And literally anyone can be a Zoom patient. My dad is a retired federal agent, and he is not technologically savvy at all, but I was able to call him and get him to change from Candy Crush and golfing on his iPad to downloading Zoom, and it took about 15 minutes, and we got him up on Zoom. and then all you had to do was click the link and he became one of our Zoom patients. And every time we brought more patients in, from our improv actors to our family members to our fellow educators, they just kept making the simulations more rich and higher in fidelity. So I have to thank Dr. Bill Toon. He jumped into a bunch of ours and started bringing medication labels and bottles in and was holding up to the camera and making our students actually read the medication labels. My dad was using his own medical history to be the patient, so he was providing them with the way that he understands medical complaints he has and what he calls them versus just reading off a script. So really awesome interaction for our students. This is one of the simulations we picked. So we picked a toxicology case. So we have 127 pages of objectives at UCLA, and we're trying to hit all of these throughout the program. A couple of them are things like demonstrate the ability to intubate someone. Well, we knew we weren't going to be able to do that objective on Zoom, but when we looked at a bunch of our objectives, they really had nothing to do with touching somebody. So we did not need a mannequin. We did not need you to touch a person. These were all higher level objectives that we could accomplish through good assessment and good differential conversations and debriefings. So we were able to meet all of the things that we normally would have done in person with most of our Zoom simulations. So bonus, as I mentioned, was that when we had traditional mannequins and skills rotations, we lost the objectives of professional behavior, we lost the documenting objectives, and we lost a lot of the effective communication because they were just communicating with people that they communicated with every day. They didn't have to change their communication style to meet a different age range or a different regional population or anything like that. It was just, this is the guy that I sit next to in class all the time, and we're gonna joke and we're gonna have fun, and I'm gonna like palpate his abdomen too hard so that I get him to groan. All that silliness that sometimes is hard to rein in, that was just immediately wiped away. We didn't even have to focus on it at all. And they were interacting with our actors and our simulated participants at such a high level. It was really wonderful to see. So we took this toxicology case here, and again, I shared the resource that we made out of it, but it just opens with a static picture that sets the scene. And we just grabbed this off of the internet, something that was available for free in Creative Commons. Then again, my dad zoomed in, so he would turn his camera on and he would be the patient. We'd have an instructor facilitator, and in this particular scenario, he's serving as the patient's son. I think sometimes he was his nephew, it just depended on how they wanted to play it. And my dad on his computer actually had the AMLS scenario there, so he could look and easily reference if there were any questions, and our instructor had it as well. So on their screen, they had the Zoom class and they had the scenario up. And then Dan is the instructor for this case. He didn't have a iSimulate at his house. So Colin created static images for him to push up onto the screen for whenever they needed it. And again, it started out with just a pleth wave when they put the pulse ox on first. And then we had them put the EKG on and they got that information. We even had them have to like wait the right amount of time for the automatic blood pressure cuff to populate. And then if they asked for capnography, we would switch it to that screen. So it was really just making them ask for all the information. Instead of just providing all of it, we found that we were able to meet more learning objectives when instead of just putting up all the vitals, putting up all of the secondary information, that we provided to them as they got it. One of the innovations, I've been lucky to work with a bunch of different educators, and we took this idea to GW's medical school for their 3rd and 4th years who were just learning about ACLS and getting ready to go into clerkships. And what they found was really helpful is they transitioned the PDF into a Word document. So the medical history, the signs, the sample, all of those findings, they kept in a Word document that was open, and then all the instructor had to do was copy and paste that information into the chat, so they didn't have to retype it each time. And so whenever one of the students was in charge of getting medical history from the family members, they would private chat that chunk of information into that student, who then had to figure out how to relay it to their teammates. When we got better at this, again, we were able to use videos. So we were able to record the screen and then have the monitor be a video in the background as the students were working. And then we also had them any one of our instructors who had a live monitor could do that with them too. So, see if that works. Okay, just a little delay. So the monitor would play as they would go, and then of course the instructor would just on their tablet, their control.
Hey, Katie, did you lose connection?
And one of the things that happened was our volunteer patient picked out clothes from our donated clothes pile that they could wear as a patient, and they picked out khaki pants and a red polo shirt. And when we first did the simulation in person, everyone was just assuming that they were at Target because the guy was wearing khaki pants and a polo shirt, and we're like, oh, I guess picky patient's gonna actually happen at Target now. And so it became something that happened naturally in the students understanding the fidelity of the simulation. So when we started to do it on Zoom, we decided to keep it with Target. Ed threw on a red hoodie and put up a Target background. So when the students come into the breakout room, he meets them at the front because he's the Target manager, and then he walks them down into the aisle. And so when they changed the aisle, Hillary actually took a whole bunch of stuff that was at her house, put it on the floor and set it up so that it looks like she's in a housewares aisle and she has fallen on the ground. And she actually had like high-heeled shoes there. And the entire learning objective of this simulation has nothing to do with treating the patient. She is not injured in any way. But the goal is to get them to be able to deal with somebody who is just being the most annoying patient you can imagine. So for whatever the group was that came in, if it was a female, Hillary would not let the female be the lead. She would say like, nope, I don't want to talk to you, I want to talk to that guy over there. Or she's like, I just don't like the tone of your voice, so I just don't want to talk to you. And they had to work as a team to figure that out while maintaining professionalism. So this is part of our EMS systems block for these skills. And it actually translated to Zoom perfectly well. And the great thing was that once that Hillary was done being the patient, she then just moved her camera to where she was sitting in a chair and put on a scarf and looked more like she was professional, and then was engaging in the debriefing. So one of the things that we would want to do in simulation and good practice is a great pre-brief simulation and then move to a different location for debrief. And so we were incorporating all of these tenets of good practice and simulation into the Zoom environment, and then really allowed them to have good debriefs. So I see there's a couple questions coming in, but for whatever reason, I'm not super great at a webinar and it's hard to see there. So the sim studies about how the effectiveness, I can definitely find those for you guys. They're published in Nursing Simulation as a journal. For our actors, we actually didn't compensate them. So every one of them was a volunteer. The only thing I did, I was able to get some funding was some Amazon gift cards. So to thank them for their time, we got them Amazon gift cards. Most of our participants in a traditional setting would just get free lunch. So we have food trucks that come to our school, or we have a cafeteria that's nearby. And so we would just buy them lunch. So we took that money that we would have normally spent on buying lunch, and we're able to put it towards gift cards for our actors and for the people who are volunteering. My dad didn't get anything but a big thanks from me. So I think there was a question about being recorded, and it definitely is. Yeah, so we are using audio. So in ours, all of the students have their cameras on if they have that technology. Some of our students actually had webcams that broke during the course of this program, or they have really low internet connectivity or low bandwidth. So for those students, we actually had them turn their cameras off and go audio only, but they could see our screens. And that's another reason why we went from sometimes having videos to having static images, and then also providing them with the PowerPoints in PDF form, so that the images are compressed and it doesn't use all their bandwidth if they needed to download it and look at it later. So those are some of the things that we try to deal with for students that couldn't participate the same way. And then if students also had trouble with background audio, so many of you might actually be watching this webinar with your children homeschooling at home, or a spouse or someone else that lives in your house on another meeting somewhere. And we realized that that was a reality for a lot of our students. They either had children at their home or they had other people who were using the same kind of technology. So one of our students' mother was an instructor who was teaching on Zoom and needed to have the bandwidth so that she could be live and presenting to her class. So during her class time, she turned her video off and then actually just responded to us in the chat, so there wasn't an audio issue. And we just made that adaptations there. And really, by being flexible with the students, they were willing and engaged to work with us. So if we showed them a little bit of flexibility, like, okay, well, do you think you can answer in the chat? They answered in the chat immediately. So it was almost like they were now engaged with wanting to participate. Instead of sitting back and waiting to be called on, they would engage in the chat. One of the things that we did was when we had large groups, so in small groups of about 5 to 6 students, we had one instructor facilitator in each breakout room. When we started to get larger groups of like 15, 20, or 30 students, we ended up adding a TA, which would be another one of our staff or instructors who specifically monitored chat features and if students raised their hands, so that the person who was potentially leading or facilitating had the backup to make sure they weren't missing someone. And this is something that I learned from the Center for Medical Simulation. When you have large groups, it's really great to have 2 people doing the debriefing in simulation, so you can make sure you're covering all your bases and kind of team debrief. And so we were able to do that with a lot of our simulations, because the people who were volunteering to help us were also EMS educators and also people who understood debriefing principles. And again, they just volunteered to help us. I literally posted something on Twitter and Facebook and was like, hey, anyone bored? Want to come join UCLA's paramedic class? And the response was overwhelming. Ed did the same thing. We joke that Ed has more friends than I did, because Hillary and a bunch of other people responded to Ed that they didn't respond to me. So it's fine. I've gotten over it a little bit. Other things that we're doing here at UCLA, and this is a shout out to Michael Caduce and his EMT team, but they're looking at, with EMT, there's a lot more discrete skills that they have to learn. So they've been really creative with, well, what can we use in their houses to show us that they know how to do stuff? And they're using Flipgrid so that students can do this at their own time. And that really avoids the errors of everyone's trying to use the bandwidth at the same time, or I've got to do homeschooling with my kid, or hey, I've gone back to work because I'm not in class anymore, and so I'm working an ambulance shift when we would have normally had class time. I think they even had one student who like moved home and is a few states away now, so there's time change issues. So they're having the students record and send it back into their instructors, who then watch the recordings for their assessments and provide feedback. So it's not exactly synchronous, but it's still great simulation, great feedback, and it's what Dr. Davis in her fancy educational terms would call deliberate practice, which we know is a great way for them to gain competency in psychomotor skills. So that's Mike. He made himself an oxygen tank and a regulator, and he even made a nasal cannula to go with it. So super creative, just using stuff that he had at his house. I was mentioning that we did this for the GW's medical school, and what they ended up doing is to increase engagement from their medical students was the team would meet, come to a breakout room, and they were told to bring a couple household items. And then during the simulation, they had almost like a scavenger hunt component. So just like if you were in a hospital setting, not all the equipment is in the room, and they wanted to simulate that and really take the time it would take to set equipment up. But knowing students don't have specific medical equipment at their house, they just replaced the medical equipment with household items. So they wanted to do an advanced airway, they needed to get a laryngoscope and they needed to get an ET tube, and so that could be things like a spatula and a straw. Or if they needed to get a backboard to do CPR, they needed to have some kind of hard flat surface behind the student, they needed to send someone to go get a pillow or a towel or whatever. I don't actually know the specifics that they came up with, but that meant that the student had to leave what they were doing, go get the equipment and come back. And then the added bonus was, now that they had missed some portion of what had happened in the code, that communication, ensuring everyone's on the same page and closing the loops, became much more difficult than if they were all just sitting statically listening to the case progress. So it added the component they were looking for, which was people when they're doing an IV can get tunnel vision and not hear that the rhythm is changed, right? And so if they were doing an IV to give an antidysrhythmic and now the patient's in PEA, it's really important that the team leader keeps them on the same page and say, we're in a different algorithm now. That's not the medication that we want to use. And so by forcing the students to leave the area that they could actually hear the Zoom call, it added that dynamic and got to those learning objectives that they were afraid they were going to miss. So that's a wonderful innovation that they took to add to their ACLS kind of training. So I just want to thank all the people that came together for our online paramedic skills, and literally without their willingness to volunteer their time, their resources, their social networks, this wouldn't have been possible. And I'm sharing this because some of these people I didn't even know until they were connected to me by someone else who saw my post. So the resources that are out there in the community that can help you is so rich, and you would think that people are all as busy as you are and that they don't have time. But I found even the people who were super busy were willing to give up 2 hours of their afternoon to be a patient in one of our simulations and one of our scenarios. And with just little encouragement that the technology wasn't something that they couldn't get through, they jumped in and they did a great job. So literally like 10 minutes of talking to them on the phone and they were set, ready to go. So I would encourage you to reach out to everyone in the EMS community, post on the NIMSY forums, post on your social media. And if you want to reach out to us at UCLA, we're happy to help and join in on your classes. We clearly have a lot that we need to repay. So for sure, let us know. Our scenarios lasted anywhere from 10 minutes to 20 minutes, depending on the complexity and what learning objectives we were looking to meet. So when we were just doing technology review, we would do very quick cases. When we were doing static cases where it was mostly about, do you know the algorithm? Can you identify the EKG? Those were some that were under 10 minutes. But then when we started getting into the complex communication scenarios, those would go for around 20 minutes and then a debriefing. I'm sure that we're going to send out the presentation later so that you can share it with your educators. And then the gift cards, we sent out $25 gift cards from Amazon. So that's what we were able to figure out. And that really came down to the budget we already had, which LA prices, $13 for lunch plus parking at our facility. And so when we combine that together, that's how much we would have spent if we had done these in person. So we were able to convince the powers that be that it wasn't a new expense, it was literally the same expense we would have had. And then we got really creative. So by having all of our full-time faculty jump in from the EMT team and the paramedic team, we were able to save on our instructor cost. And that's how we were able to afford the heart code, which they're $132 each for American Heart. So that's totally, I can see how that would be out of the realm for a lot of people. But they do have streamable videos. So if you have the time and you have the staff to do it, you could actually do all of heart code or all of the regular ACLS course via Zoom. And that's totally okay from the American Heart now. The only thing that they're requiring that you do in person is the CPR. So you can make sure you have high quality CPR. So what we did, or what we're planning on doing, is when the students come back, we're going to social distance, and we're going to use the reality CPR module that we have, and that also allows us to distance. So we have the wristbands in the mannequins, and it's going to give us CPR feedback directly on the screen that the students can see and that the instructors can see, and they'll be videotaped so the instructors don't even have to be in the same room. So that's our plan to finish out some of the actual physical skills that need to be assessed. We were lucky that we had done that, most of them in the program prior to having to be stopped, but when they come back, we actually want to do mega code testing with them, and including in the high fidelity, or high quality CPR. So we're going to continue to use the reality system, literally the same one they learned on, and then they're going to just add the CPR module component, and it's going to be recorded, which also will allow students to go back, since they have the CPR quality, the EKG rhythms, the monitor, and all of the actions of their team members recorded. We can post those recordings and students can do self-reflection from the simulation recording. So we're really excited about that last transition and piece. And we're hoping that because we've done so much work online and we have gotten to such a high level of critical thinking, that the students will now have less time needed to get the physical skills there. They've gone through the checklist, they know the indications, they know when to use them. All of the hard questions are kind of already taken care of, and we just need to do it in person and have them get checked off. So here's my contact information and a link to the slides. So whatever we have, I'm happy to share. The QR code here is for a Google form to fill out. One of the things that has been happening is like overwhelming my inbox with people asking for resources and needing help with stuff. And NIMSY has a trading post that has all of this material, like tons of materials you can't even imagine. So I created a Google Drive to share those materials, and then specific folders for stuff that people are creating during this like current time. So I've been posting that there. The only thing is you need a Google, a Gmail type email address for me to be able to add you to the drive. It doesn't let me share with someone who doesn't have a Gmail address or equivalent. So if you want to fill out that form, I'm happy to add you to the shared drive that has all of the Trading Post resources and all the stuff that we're coming up with, and like these PowerPoints that I was showing and some of these iSimulate videos that we've created. Happy to share with everyone. The only thing I ask is that if you take something that someone has their name on, just let them know that you used it, or give them some props in your presentation when you do it. So I think that we're a community of educators and we all need to stick together. So happy to share anything I have. And if you have any questions, please start throwing them in the chat and I'll answer them as we go. Yeah, so scripts and playbooks written up. We do have a few. They're not super in depth. We do rely a lot on the patients working with the students. So responding to the students the way they're phrasing the question. So for like the picky patient scenario, if the students are doing a really good job of communicating effectively and communicating in a proper professional manner and using active listening skills, then the patient's given the direction to be a little bit nicer to them. If they're doing a bad job, then the patient's supposed to react the same way they would. One of the really awesome things that came out of that is Jonathan Epstein, who is with Jones and Bartlett Learning. He actually came in and became part of our patients. And one of the students was like, well, you know, this is my partner. He's like, your partner? Really? And it like started to get, and so the student got flustered and was like, no, I mean, he's just on my team. Oh, you back for that team? And it was something that I probably would not have scripted, but it literally threw our students off so much. Just those like couple comments from Jonathan, they were just like, they had no idea how to answer it. They had no idea how to deal with it. One of our administrative assistants is teaching the CPI course, which is a course for the hospital system about de-escalation and managing violent patients and patient visitors. And he had some availability because a lot of our administrative tasks have kind of ceased as the office closed. So he jumped in as a patient and we put him in a situation where he was a suicidal patient. And he was able to take just his knowledge of CPI and add that to our course. I don't teach CPI. I've never actually gotten to take the class. I wouldn't even have been able to script that, but he was able to do it. And the feedback from that suicidal ideation scenario was great. A lot of our students commented that they had never talked to somebody who was suicidal before, and they had no idea how to breach these conversations and even just ask questions. So I think sometimes we really focus on, especially with Appendix G, and I'm just gonna say it, they're like nonsense numbers, that we focus on how can we have 75 advanced airway scenarios so everybody gets a chance to put in a bazillion intubation tubes. It's important that they learn that skill, but I would argue it's actually more important that they can communicate effectively with patients. And so this whole process has really shown us that focusing on those communication aspects of the sim enriched the students' education and made them want to participate in the simulations, because it was something they had never gotten to do before in their limited experience as IFT or interfacility transport EMTs. Yeah, so for us, for Appendix G credit, we are. So again, we're recording these in FISDAP. We're making the students write the reports just like they were doing. We actually are putting the skills in that they did as observed. We think it's really important that the knowing when to do a skill and knowing which skills are appropriate is actually the learning objective that we're focusing on. We have more than enough discrete skill practice on a lot of stuff. We're not concerned that they can do an IV. They do a bazillion IVs, and they're going to when they go to clinical and field, which I'm not sure exactly how that's gonna look like, but some of our clinical sites are opening. So our students push something like an average of 120 medications. Not so much worried about that. I'm more worried that they know when it's appropriate to give a medication and the contraindications, the side effects, and all of that. So we are making them record that they chose that medication and that they looked for the effect and reassess the patient looking for specific things. And we're making them record that in FISDAP so that we can track that they were actually doing the higher level cognitive functions around that. And then of course we have in FISDAP ways for them to just enter quick skills so we can check that they physically did the skills too. So students are putting in that they're team members and that they're team leaders. The other logistical concern here is if we didn't do this, 48 students, according to Appendix G, all of them need to lead one geriatric stroke. So I can't really keep waiting to do 48 geriatric stroke scenarios with these students, and it wouldn't be a good learning situation for them anyway. So they're getting so much value out of this learning, and that's really the point of the scenarios and simulations in Appendix G, is to meet learning objectives and show a progression of learning. So I think that's what we're doing, and that's why we're recording it that way. Yeah, so Chris is saying that we haven't addressed the problems of actual skills practice in clinical scenarios. I think, well, so for hands-on practice, one of the things that they're doing is what we're talking about with Flipgrid. So if you're thinking of hands-on trauma assessment, so I'm thinking of the National Registry Station, that station is designed to be all completely verbalized. And so what we've had students do, and it's mostly on the EMT team, they're working on that specific hands-on station, is they have sometimes it's a stuffed animal, but sometimes it's the person that they're self-isolating with or social distancing with, maybe they're in a house with them, and they record their hands-on assessment on Flipgrid and then provide that to the instructor who watches it and provides that feedback. So it is actual psychomotor skills acquisition, and they're doing the psychomotor skill of the assessment with hands-on approach. For us, we actually think that the knobology of pushing the button on a computer screen is the same as pushing a button on a monitor screen. So we're considering that the discrete skill of literally knowing what buttons and what order to press. That's what the defibrillation and cardioversion skills are. Can you remember to hit the sync button? So that's what we're doing there. And then the hands-on practice, again, you have to look at what the learning objectives are. So at the paramedic level, we were not super concerned about the ability for them to use a bag valve mask, which is part of the ACLS hands-on skills, because we've already covered that in our course. Now, when they come back, we're going to make them do it again, but they have to do 50 ventilations throughout the course of the whole program. And what we're looking at here is, do the objectives that we're trying to meet, are they being met, or are we just too focused on can they BVM or can they use an OPA, which isn't really the point of the whole ACLS course. It's just a small component of their testing. And it's actually not required because all they have to do is use BVM. So any of the intubation stuff in ACLS isn't part of the course. It's just things you could add to it. So when we really looked at that perspective, we saw that we were meeting the objectives of the course with this online environment. We still do have to bring them back, and we're going to have them do IVs and pull up medication from a vial before they go to the clinical setting. So we are still working on that too. Right. And so then the teaching the CPR skill remotely, specifically looking at, if you were looking at in primary CPR learners who've never taken a CPR course before, the UCLA's medical school is doing this for the students who are going to resume from a break to go back to clerkship. And so what our plan is, and I can't speak to having done it yet, but our plan is to have the students come to and use, actually, they're going to use the Laerdal QCPR mannequins. So if you have the mannequin with the Bluetooth app, you can actually be 6 feet away and be getting the feedback about the compression quality and the ventilation quality. So it doesn't help for people who don't have that mannequin. If you have the iSimulate reality system, they actually do the same thing too with their wristbands, or you can put the bands into the monitor. Some of our early kind of figure this out as we go was that right now the American Heart Association is offering free shipping, and they have the CPR Anytime mannequins. So there's a couple apps that were being used. One, I can't trying to think off the top of my head, but one of the apps was designed to use your webcam or FaceTime on your phone to give quality CPR quality indications to the 911 dispatcher so that they could see you and see the compression quality and then give you feedback. So it's a pilot that they're doing to actually improve real CPR, but the app is free and you can use that if you don't have a reality system or you don't have a QCPR system. They would just kind of need some kind of mannequin to do that with. That gives them some level of resistance. You couldn't really do it with a pillow at home. But if you got the CPR Anytime kit, my thought was they're $35 each. We could get like 4 of them. They're offering free shipping right now. And then we could send them to students and then we would just rotate those. So if we had to, we would have Zoom, we'd have video camera, we would use this app that they've developed for dispatch CPR quality and then teach CPR through that. Yeah, TCPR link, thank you. Sorry, I was like not expecting to talk about that. Zola used to have an app too that gave you feedback with just holding your phones when you did CPR, but it looks like they took it off the market in the US. It's only available in I think the UK now, which I don't know, someone on this call is probably like super technology savvy and can figure out how to get it, but that's what our thought was. So the only thing you need to be able to do is still get that feedback on compression depth, recoil, and ventilation. And so we thought we could do that with the CPR Anytime mannequins and those apps. So, the other option is that they're going to do a video recording. So just set up either a phone or an iPad and record and then just stream that to an instructor who's 6 feet away or in a different room. And that's how they're gonna get most of the individuals that need to get back into clerkships done. I think GW Medical School is doing the same thing. They were doing one-on-one sessions for heart code CPR, and then that was meeting the local restrictions for distancing. Great. So I think I hit all of the questions that people put in the little question box, but happy to answer anything else, or I don't know, are we out of time?
So we are running right up on the hour. If anyone has any questions right at the last moment, please feel free to send them in and we can get to them. But I do want to take a moment real quick while we're here and I still have some people on the line. I had some people send in a message notifying me that apparently the automatic email yesterday did not go out for our webinar. So you'll receive 2 emails if you attended yesterday and today. You'll get that information sent directly to you. But go ahead and watch your inbox for the email today. So it has this contact information that's on the screen for Kathleen, for Katie O'Connor. It'll have iSimulate stuff. It'll have NEMSI's webinar resources, the NEMSI forums that Katie talked about during the presentation. It'll have links to that and everything. So that'll go directly to your email after this. Let's see. I think it looks like we're getting mostly thank yous coming in. So if anyone has any last questions that you've held off on, I don't want to speak for Katie, but I think it's okay to go and reach out to her separately. And
yeah, and Caduceus is on this webinar too. And if you're really interested in discrete skills, they have really been doing a lot of them on EMT. Again, for paramedic, it just doesn't meet the learning objectives we needed to cover, but they've been doing a lot with that too. So I'm gonna just throw him under the bus right now and say that he's also willing to help with that. So reach out.
Great, thank you. So yeah, like I said, watch your email inboxes. You'll get all this information sent directly to you. You'll get a recording of the webinar. This presentation will be made available. So you have lots of resources available to you, and thank you for tuning in. Keep checking out NEMSI's social media, and we're going to have as many webinars as we can get in the future. And so thank you very much, Katie, for the presentation today. It was super informative, and I think everybody benefited a lot from that. So unless you have anything else to say, I think they're pretty much good.
No, I'm sure people are tired of listening to me, so thanks.
Thank you, everybody. Have a great day.